Hey, y'all. I want to go over some NCLEX things they forgot. Talking about fluid and electrolytes, specifically potassium. I've been doing NCLEX boot camp for graduates, and these are the rationales of some of the questions that we've had, and I just wanted to go over them with you. They're not in any kind of order, but they're bullet points, and I hope it helps you. So flaccid paralysis with respiratory depression is associated with hypokalemia. Generalized weakness is a manifestation of hypokalemia. Orange juice is high in potassium and would be advisable to drink if the patient was hypokalemic. IV KCl is administered at a maximal rate of 10 milliequivalents an hour. Rapid infusion of KCl can cause cardiac arrest, Father God. KCl can cause inflammation of the peripheral veins when it's administered, intravenously. And cardiac monitoring should be continued while the patient is receiving potassium. Why? Because of the risk of dysrhythmias. Hypokalemia, you got to know this right here, increases the risk of digitoxicity, which can cause serious dysrhythmias. So before you give dig, you got to check the apical heart rate for 60 seconds. If it's less than 60 on an adult, you hold it. Less than 90 on a child, you hold it. Less than 100 on an infant, you hold it. But if they ask what your priority is before giving dig and checking the apical pulse in there, if it says check the potassium level, you want to do that, because it'll just fling them over into digitoxicity quicker. A change in LOC could be indicative of fluid and electrolyte disturbances. Which ones? Here they are. Extracellular fluid volume excess, fluid volume deficit, hyponatremia, hypernatremia, hypokalemia, and metabolic alkalosis can cause a change in your LOC. Hypokalemia is present when the serum potassium level is less than 3.5. Loss of potassium can cause dysrhythmias and seizures. So we may need to fling a little bit of seizure precautions on them. Hypokalemia can cause slow, smooth, and skeletal muscle contractions. Liquid or tablet potassium supplements are given with a glass or more of water or juice, or with food to prevent GI irritation. Intolerable GI side effects may lead to noncompliance with treatment regimen. So tell them take it with a glass or more, or some orange juice, or to eat it with food. For severe potassium deficits, 10 to 20 milliequivalents can be given every hour if it's diluted in IV fluids. A cardiac monitor must be used to ensure safety. IV potassium, my Lord, cannot be given IV push. Don't do it. Potassium products should be agitated before administration to prevent an unintended bolus. The drug should be given with adequate dilution using normal saline through a small cannula. The site should be changed every 2 hours, every 72 hours or sooner if tenderness develops. So I'd put this on index cards and flash myself till I knew all these normal ranges. Plasma ranges, sodium is 135 to 145. Potassium is 3.5 to 5. Chloride is 98 to 106. And calcium is 9 to 11. Sometimes they'll say 8 to 10, but it's going to be markedly higher or markedly lower. The nurse should report even borderline potassium levels. Why? Because general anesthesia promotes potassium loss, and in combination with a low plasma potassium level, synergistically increases the risk of dysrhythmias. Insulin promotes the entry of potassium into the cell from the bloodstream. Therefore, patients with persistent insulin hypersecretion may experience hypokalemia. Potassium-losing diuretics such as thiazides and loop diuretics can induce hypokalemia. Thiazide and loops. Other medications that can lead to hypokalemia, they're going to list them for you, isn't that sweet? Include corticosteroids, sodium penicillin, amphotericin B. GI loss of potassium is another common cause of potassium depletion. Vomiting, gastric suction frequently leads to hypokalemia. Why? Because potassium is lost when the gastric fluid is lost, and because potassium, go away. Because potassium is lost through the kidneys in response to metabolic alkalosis. Okay. A client with a low serum potassium level may exhibit hypoactive bowel sounds, cardiac dysrhythmias, muscle weakness resulting in shallow respirations, Father God, or decreased hand grips because of his muscle weakness. Manifestations of hypokalemia, bradyapnea, they're breathing like 8 breaths per minute. Absent of deep tendon reflexes, and a U wave present on the EKG. Manifestations that indicate treatment is improving the hypokalemia. If they have active bowel sounds, that indicates the treatment's working. If they have increased muscle strength, if they have a strong productive cough, that means their respiratory muscles are, kicking back. Signs and symptoms of hypokalemia: fatigue, anorexia, nausea and vomiting, muscle weakness, polyuria, decreased bowel motility, ventricular asystole or fibrillation. And look, fibbing is quivering. That's not contracting. Paresthesias, leg cramps. When your foot goes to sleep and then it starts waking up and you don't want nobody to touch it? That's what paresthesias are. Yeah, leg cramps, decreased blood pressure, an ileus. That's where his bowel done gone to sleep. Abdominal distension and hypoactive reflexes. And look, on the EKG, the potassium is low. So it's like everything is pushed down. The flattened T waves, they got a prominent U wave, ST depression, and a prolonged PR interval. Everything's kind of pushed down. A client with continuous nasogastric suction would be at risk for actual potassium loss leading to hypokalemia. In a client with hypokalemia, progressive skeletal muscle weakness is associated with increasing severity of hypokalemia. The most life-threatening complication of hypokalemia, Father God, is respiratory insufficiency, because his muscle weakness, he can't even suck air in. My goodness. It is imperative. You see that? It's not, they don't suggest it. They don't say you may want to think about it. They said it is imperative for a nurse to perform a respiratory assessment first to make sure that the client is not in immediate jeopardy. Cardiac dysrhythmias are also associated with hypokalemia. The client's pulse and blood pressure should be assessed after assessing the respiratory tract status, whatever. Next, the nurse would call the healthcare provider to obtain orders for potassium replacement. All that was about hypokalemia. And here's some foods. Fruits that are relatively low in potassium and can be included in the diet. So these are low. You would give these to people with hyperkalemia, but look, you just hang in here. Apricots, Apples. I know I did it backwards. Berries, cherries, grapefruit, peaches, pineapples. Cranberry juice and lima beans and corn are low in potassium. Eggs, bread, cereals, sugar, and some fruits, like berries and peaches, are low in potassium. So we would give those, we would tell the people with hyperkalemia about those, but fruits high in potassium, and you would encourage people with hypokalemia to eat them, include bananas, kiwi, cantaloupe, oranges, and dried fruit. Cooking fruit doesn't alter its potassium level. That's just a little you're welcome. Meat, dairy products, and dried fruits have high concentration of potassium. Bananas, broccoli, and cantaloupes are considered high potassium food. Aldosterone is a naturally occurring mineral corticoid hormone that increases the reabsorption of water and sodium. You see aldosterone got an S in it. It tells the kidneys to save salt and water follows. Okay. And when you remember, I don't know if you watched another video, but if you are saving sodium, you're excreting potassium, because you just can't have it both ways. That's not how God meant it to go. Lock that in your frontal lobe right there. Any drug or condition that disrupts aldosterone secretion or release increases the client's risk of excessive water loss, because aldosterone tells the kidneys save salt. And water follows that. Excessive water loss or increased urine output, increased potassium reabsorption. Because if we don't have nothing telling the kidneys to save salt, we're losing it. If you're losing salt, you're saving potassium. That's the law. Decreased blood osmolality. Increased urine-specific gravity. What is all this now? These are problems is coming if our aldosterone secretion is jacked up or not allowed. So here's hyperkalemia. High potassium levels have the potential to induce life-threatening dysrhythmias, and the nurse would monitor and report EKG changes. I'm telling you, you hear me what I'm saying? When severely elevated potassium levels with it, the myocardium will be unresponsive to medications or defibrillation. So changes to the EKG need to be reported immediately. Now, we're talking about high potassium. It's high. It's like it's pulling the T wave up high and making it peak like that. Peak T waves. On hypo, it was flattened T waves. I believe you're picking up what I'm putting down. Loose stools are associated with hyperkalemia. Hyperkalemia affects clients with acute and chronic renal failure. As hyperkalemia persists or increases, a cation exchange renin, such as sodium polystyrene sulfonate, may be given orally or rectally as a retention enema. When they got hyperkalemia, they'll shoot this up their little hiney booty hole, and it'll help them. Because spironolactone is a potassium-sparing diuretic, patients should be taught to choose low potassium foods. This will be on your NCLEX, you hear me? Like apple juice, rather than foods that have high level of potassium, like citrus fruits. Because the patient is using spironolactone as a diuretic, the nurse would not encourage the patient to increase their fluid intake. But this is what you got to teach them. Dadgummit, you hear me? If they're on spironolactone, you see that? We have to teach them to avoid salt substitutes. Why? Because they're high in potassium. A client with a high serum potassium level and cardiac changes should be treated immediately to reduce the extracellular potassium. Electrolyte imbalances that are related to renal failure are hyperkalemia and hyperphosphatemia. So you're going to assess for electrocardiogram changes, a paralytic ileus. That means his bowel done went to sleep. And it's caused by, because the bowel ain't got no peristalsis. It's just laying there. God love him. Skeletal muscle weakness in clients with hyperkalemia. That's what you're assessing for. Potential complications of hyperkalemia, electrolyte imbalance, EKG changes, a paralytic ileus, and skeletal muscle weakness. You see how many times they said that? Potassium movement into the cell is enhanced by insulin. By increasing the activity of the sodium-potassium pumps, insulin will decrease both serum potassium and glucose levels, and thereby should be administered with dextrose. You see that? To prevent hypoglycemia. I believe you do. K-exolate makes that potassium exit may be ordered. But this type of therapy, the suck of that is, it may take hours to reduce the potassium levels. Dialysis may also be needed, but this treatment, it's going to take much longer to implement, especially if they don't have no dialysis access. And it's not the first thing the nurse should implement. Okay? Signs and symptoms of hyperkalemia: muscle weakness, tachycardia, bradycardia, arrhythmias, flaccid paralysis. It's just, never mind, shut up. Paresthesias, intestinal colic, cramps, abdominal distension with hyperkalemia. They ask that a lot, so lock it in your frontal lobe. Irritability and anxiety. Look at the EKG. It's the potassium's high, so it's pulling that peak wave, T wave, making it tall and tinted. A prolonged PR interval and QRS duration. And eventually, you'll have an absence of P waves when it gets really severe. And ST depression. The most important consequence of hyperkalemia is its effect on the myocardium. Cardiac effects of elevated serum potassium are usually not significant when the level is 7 or less. The normal for potassium is 3.5 to 5.0. So you're not going to see a whole lot when it gets to 7. However, they're almost always present when the level is 8 or greater. As the plasma potassium level rise, disturbances in cardiac conduction occur. The earliest changes often occurring at a serum potassium level greater than 6 are peaked narrow T waves, ST segment depression, and a shortened QT interval. If the serum potassium level continues to increase, the PR interval becomes prolonged and is followed by the disappearance of your dead blank P waves. Finally, there is decompensation and widening of the QRS complex. Okay. Ventricular arrhythmias and cardiac arrest may occur. My goodness. The nurse must caution patients to use salt substitutes sparingly if they're taking other supplementary forms of potassium or potassium-conserving diuretics. In addition, potassium-serving diuretics, potassium supplements, and salt substitutes should not be given to patients with kidney injury. You got to watch them kidneys when you're dealing with potassium. Okay? I hope that helped you. I'll be coming back with more.